Welcome. I'm Oxiris Barbot. I'm President and CEO of the United Hospital Fund. And thank you. I'm going to raise this just a tad. And on behalf of UHF, it's my absolute pleasure to welcome all of you to our 17th annual Medicaid conference. For those of you that are new to the United Hospital Fund, let me start by saying we're not United, we're not a hospital, and we're not a fund. But what we are is an independent nonprofit focused on building a more effective and equitable health system for all New Yorkers. And we've been doing that since 1879. We work towards that mission through research and policy analyses, hosting fellowships and demonstration programs, and convening diverse stakeholders to find common ground for solutions to pressing challenges in healthcare. And the through line in the work that we've done since 1879 is health equity, right? It may have looked differently, the programming has been different, but our focus has always been to build a better health system for all New Yorkers, but especially for those in most need. And as you all know, there is tremendous value in convenings like this one that bring together such a diverse group of stakeholders, including state and local government, healthcare delivery systems, providers, plans, community-based organizations, academics, policy experts, and Medicaid members. The opportunity to learn, ask questions, provide feedback, and foster innovation furthers our collective goal of strengthening and improving Medicaid's programming. So it's great to see so many of you in person from across the state for the second time that we're hosting this at the Bar Association. And a warm welcome to those of you that are joining us online. I believe the camera is straight ahead. Right, Chad? Where's Chad? Chad is my peripheral brain. And it looks like we are breaking records. So last year we broke a record. We had over 900 registered attendees. This year we broke 1,000 registered people. So we've got just over 400 in person in this room and in the overflow rooms, and more than 700 are joining us online. So it's exciting. And, you know, I've been thinking about, well, why is this? And there are many reasons why I think we've broken our attendance record. I'm going to give you just three. One is we put on a great conference. Right? We bring together knowledgeable speakers and present timely topics on things that are relevant for all of us, whether we are Medicaid recipients, Medicaid providers, academics, plans, et cetera. Two, this conference is a great opportunity to network, right? To see folks that you haven't seen since last year's conference, to meet new people, to talk about what's going on and how can we collaborate. And so that's why, you know, we have a bigger space, and that's why over 400 of you wanted to be here in person. We had a waiting list. We tried our best to accommodate folks. So next year, I don't know what we're going to do, but it's going to keep growing. And then the third reason why I think we're breaking attendance records, and especially during this time in our history, is that we are creating and cultivating community, right? The fact that you're here in the middle of July or at the end of July, when there are so many other things that you could have been doing, but you chose to be here, says a lot about the importance that you place on Medicaid, how interested you are in knowing what's happening, and how you're interested in identifying opportunities to keep supporting the great work of Medicaid in this state. So I applaud all of you for taking time out of your busy schedules and joining us here today. So as everybody knows, I mean, it's a challenging time for Medicaid, and I put that in quotations because you can sort of substitute whatever adjective works for you in the moment, right? Sometimes those adjectives are more colorful than others. Sometimes those adjectives a little bit more morose, but I think challenging draws sort of the right balance, if you will. Earlier this summer, the fact that this bill was signed into law that reduces Medicaid spending by $911 billion over the next 10 years and increases the number of uninsured people by 10 million is something that I would never have imagined in my worst nightmare. And as I was telling someone earlier, I thought for sure the Senate was going to save us, but it turns out not. And so, we are in a new reality. And in those new realities, we create new partnerships. We think about innovative ways to keep the work going. I have a list of things that sort of cascaded because of those budget cuts, but all of you know those exceedingly well. So I'm not going to go over them, but I will just sort of emphasize a point in that this is certainly unprecedented, but the degree to which it's all happening together and the degree to which immigrants and children of immigrants are especially targeted feels a little bit more draconian than even my worst nightmares could have anticipated. And to a certain extent, we shouldn't be surprised because programs that serve the poor have always been stigmatized, right, from the very beginning, and they go through waves. But in that, it emphasizes, and it goes through waves and it goes through the pendulum, right? But in that, it emphasizes the importance that until the pendulum swings the other way, and it will swing the other way, it's important for us to remain united in fighting for comprehensive, publicly funded health insurance for all that need it. We can't lean away from that. We have to lean into that. So if we can cue up the slide, we are excited for a day of balancing hard truths with inspiring information about what's top of mind in Medicaid. And we're delighted to celebrate this important program exactly 60 years since Medicaid was established, July 30th, 1965. Today, July 30th. I would love to say we did that on purpose, but it just, honest to God, right? The universe brings you together when you're meant to be together. And we're excited that UHF has been fortunate to play a significant role in reinforcing this cornerstone of the New York healthcare system, ecosystem, for all of its 6 decades. So in leading up to today, we issued 3 policy briefs on the key role that Medicaid plays for the elderly, disabled, and children. They are in part a testament to the way in which Medicaid has reshaped multiple times over its 6 decades to meet the dynamic needs of our fellow Americans. You'll find a copy of our blueprint on your chairs. And in that blueprint, you'll find spotlights of the reports that we wrote. And you can also access the full policy briefs via the QR code on page 5 of the blueprint. Throughout the day, we will reflect on key successes and accomplishments over the past 60 years of Medicaid's existence, current challenges and opportunities given the political landscape, and look to the future and opportunities for more dynamic innovation. So let me give you an overview of today's program. This is also a reminder to stay hydrated during the day. It is freaking hot out there. So today you're going to hear from Amir Bassiri, New York's Medicaid director, on current challenges and opportunities within Medicaid, given the cuts and what these changes might mean for our state. Then we'll transition to our morning of distinguished panelists who will talk about the evolution of Medicaid over the past 60 years and how the program has adapted to past and current challenges. After lunch, we're going to hear from our colleagues from the Department of Health who have been integral to the implementation of the Medicaid 1115 waiver and what's happening there. Lastly, we will hear from former CMMI Director Liz Fowler, who will speak about opportunities for innovation and in Medicaid and the necessity of not letting a crisis go to waste. So before I introduce our first speaker, I want to say a few words about our sponsors and how their generosity helps us increase access to today's programming. Based on last year's success, we waived registration fees for those joining online and for many attending in person, including Medicaid members, students, our colleagues in state and local government, and our colleagues in nonprofits and CBOs. Achieving this goal was only possible because our sponsors shared this priority as well. I want to give a shout out to our sustaining sponsor, the Commonwealth Fund, private foundation whose mission is to promote yes, please give it up for Commonwealth. They're a private foundation whose mission is to promote a high-performing healthcare system. Without their generous ongoing support, we wouldn't be able to have so many of you join us in person and online without having to pay fees. We also want to thank Unite Us, who brings sectors together through technology to ensure people's needs are met. They covered the cost of the virtual conference so that everybody attending virtually could do so at no cost. We also want to thank Health Management Associates for providing breakfast, Accentra Health for lunch, NICEDEC for the all-day beverage stations, and Fidelis Care for the dessert reception that will be at the end of the day. You'll hear from Commonwealth Funds shortly and Unite Us this afternoon, but I want to encourage you to visit their websites to learn more about their work. And of course, I want to give our sincere thanks to our other sponsors, Deloitte, United Healthcare, Community Plan, Equifax Workforce Solutions, Find Help, and Upstream. I want to also acknowledge that a day like today doesn't just happen. And oftentimes we leave this part to the end of the day, and I want to do it at the beginning of the day. So I want to ask all of you to join me in giving a big round of applause for all of the staff at UHF that made today possible. I want to give them a shout out quickly in alphabetical order. James Andrews, Giovanna Braganza, Adam Fifield, Matisse Gilmore, Mary Johnson, Amy Lynn, Val Magaling, Anna Quinn, Emily Regas, Joey Rodriguez, Sally Rogers, Chad Shearer, Alexis Simonetti, Alexandra Taverna Trani, Grace Townsend, and Amanda Williams. Now, just a few housekeeping things before we get started. We encourage questions during the sessions today. If you're in person, there are mics in the audience. If you're online, please submit your questions in the Q&A box. We'll be fielding questions for both locations. We want your feedback. So for those online, there will be a Zoom poll at the end of each session. Please give us your feedback so that we can continue making this conference as great as it can be. For those in person, you can access the survey through the QR code projected on the slides. And we want you to share what's happening through your social media. If you haven't already done so, follow us at United Hosp Fund on X, United HOSP Fund on X, and you'll see a tweet this morning with the conference hashtag UHF Medicaid 2025. We're also on LinkedIn and Blue Sky. So just 5 seconds over my time. I want to now introduce our first speaker. It's my pleasure to introduce Melinda Abrams, Executive Vice President for Programs at the Commonwealth Fund, one of our lead conference sponsors and a consistent supporter of this conference for several years. Melinda, please join us up here for a few remarks, and as you come up, to say how much UHF appreciates decades of support and collaboration and partnership with the Commonwealth Fund. So thank you.
Thank you. Sorry. Thank you, Oxiris, and to the entire UHF team for its leadership as a reliable source of policy research, data analysis, and convenings like this one. And the team, I can tell you, someone who goes to a lot of conferences and works at the national level, they've put together an all-star cast. It is an amazing agenda. So kudos to all of you for organizing this. So thanks. I also want to recognize our co-sponsors and partners, particularly Unite Us, who you'll hear from later. Oxiris said this, but the Commonwealth Fund is a private foundation, independent nonprofit foundation. We are based in New York, but national in scope. And our mission, which she referenced, wait 1 second, sorry, is quite simple. You know, it's to achieve a high-performance health system, which in many ways means it's about ensuring that we have affordable, high-quality care for everyone. To state the obvious, and you're going to hear this a lot today, these are really difficult times. Unprecedented, yes, and difficult. At last year's conference, I think I said that Medicaid unwinding was our #1 challenge facing Medicaid. Today, that almost seems quaint. HR 1 will fundamentally reshape Medicaid, with nearly 11 million Americans estimated to lose coverage. And combined with the changes in the marketplaces, we anticipate nearly 17 million people losing coverage nationally, with devastating impacts on people, families, providers. Just for example, we know that those working multiple jobs or who change addresses will lose coverage under work requirements if they miss a reporting deadline. We know that rural hospitals will face greater difficulty keeping their doors and lines of service open for patients as state-directed payments and provider taxes are reduced and capped. States will be forced to make tough choices, reducing the people, some of the populations they cover or key benefits. Dental, home and community-based services, hospice. And in New York, you all know, but this means that roughly 1.5 million people will become uninsured, billions of dollars in lost revenue, and more than 60,000 New Yorkers are estimated to lose their jobs. These effects will not be felt evenly. Rural communities, certain underserved populations, will bear the brunt of the impact deeply and immediately. Providers, state officials, health systems will all feel the strain, absorbing greater burdens with fewer resources. So the path forward is daunting and it's uncertain, but that's why I'm particularly grateful to be here with all of you and for UHF and to engage in this urgent conversation about the future, and particularly about the future of Medicaid. At the Commonwealth Fund, we are committed to meeting this moment. And we've identified 5 ways that we're going to double down and approach the work ahead. And the 5 are, first is to monitor, track, and report on the rollout of the new policies and its impact on the rate of the uninsured or the rate of the insured or uninsured medical debt utilization. We're going to also longer term evaluate how the changes affect people's health and security. So looking more at like mortality, health status, chronic disease, bankruptcy. There's a third role in the 5, which is to translate and communicate the policies and their effects to a wide range of audiences. We learned this from the ACA, that there's so much in this statute that, you know, we're still like trying to figure it all out. And it's really important that we continue as a community to understand it and translate it and disseminate it and talk about it, because I think there's a lot packed in there, and it will be useful. The 4th is to educate and support federal and state policymakers as they navigate these changes. So this one's a little tough, but I think it's important, because I think as we kind of translate and better understand what's in the statute, I think it's also important to kind of really point out to the policymakers like the implications that this is going to have. And there might be ways through rulemaking and other things to, you know, mitigate the blow and you know, implement some of these provisions in this least harmful a way as possible. There are going to be options, there are choices, and the understanding kind of those trade-offs and what those options are is going to be really important. And I think all of us have a role to play there. And the 5th, and the most important, is to begin now in the rebuild and reimagine for the future of a U.S. health system that provides high-quality, affordable care for everyone. It's hard to talk about the opportunity and, you know, that this current situation presents, but we need to do that. We need to talk about that there is an opportunity. I've had the privilege, really, of meeting with a lot of state officials from around the country, including Medicaid administrators from a number of red states and blue states, but a lot of red states. And their determination to continue to do what's best for their residents and focus on what they can control to ensure that people live healthy lives in spite of everything we're facing has been inspiring. And so I urge all of us to bring some of that spirit to this meeting today, to this conference, to consider how to mitigate the anticipated harmful effects at the same time as we kind of think about longer term, reimagining what coverage and care for everyone can look like. Maybe we don't build it back the way it was. Maybe we build it better. That was an unplanned. Oh my God. That was not planned. Sorry. Read what's on the paper. Sorry. So there will be future policy windows, and it is our job to be ready for when they open. This work starts now at this conference and in this room, this virtual room with 1,000 people all of us together, with great leaders and thought partners coming together with urgency, with resolve, and shared purpose. I can think of no better organization than UHF and no better place than the annual Medicaid conference to have conversations about how best to prepare for the future. And I'm grateful to UHF for convening us and creating the space for us to engage in this critical work. Thank you all so much.
Thank you, Melinda, for those inspiring words and continuing the theme of optimism and inspiration in light of extremely challenging circumstances. So it's now my just distinct pleasure to introduce our next speaker, our keynote speaker, Amir Bassiri. Amir is a social worker by training and is a tireless public servant. After working in the nonprofit sector, he joined our state government 9 years ago, first in the governor's office and then transitioned to the Department of Health in 2019, now running the Medicaid program. After working alongside Amir for the past few years, I can tell you how fortunate we are in the state of New York to have a person with his dedication and integrity leading our program. So Amir, please join us and share your remarks. Thank you.
Thank you, Oxiris, and good morning, everyone. My name is Amir Bassiri. I'm the Medicaid director. It's an honor to be here. 60th anniversary of Medicaid, and Oxiris is right that it was inadvertent that we picked this date, but I'm going to take credit for it because every year I've done this, she gives me a range of dates, and I always pick the last one. And this year it happened to work out inadvertently. So we're going to do things a little different. I will go through a little bit about, I want to take a macro view to start off, let everybody know, share sort of where we've been, where we've come from, what we've accomplished, especially in the last 10 to 15 years. And before going into how the program is going to change, as Melinda and Oxiris shared, due to the federal bill that was signed earlier this month. And then we'll look ahead as to how we're going to approach this and work with the industry to implement these changes. But you're also going to hear very clearly from the team later on the 1115 waiver, and I really encourage you to ask questions. It's not that work is still as important as it has always been. We still have a wonderful opportunity in front of us, and we have to take advantage of it in the remaining year of that waiver. But look forward to talking about that. So it's only appropriate to start off today, the 60th anniversary, with a little bit of a history of where we've come from. Obviously, it's the 60th anniversary. Medicaid was implemented the year after it was signed into law, 66, and New York has always led the way in areas of coverage expansion, starting with the Child Health Plus program, which is very underappreciated. It's the little engine that could and always has been. And in 1990, that program was created as a state-funded program prior to the creation of S-CHIP in 1997, what is known today as the Child Health Insurance Program. And New York was one of 3 states that was grandfathered in with its benefit package. And we really do like to think that New York is the reason we have a child health insurance program. And as I talk through the rest of the presentation, you'll see we've really built a foundation of coverage options on the base of Medicaid. And that has really what has created the very large safety net and public health insurance infrastructure that we have. After CHIP, we've obviously done a tremendous amount in the last 10, 15 years. Significant managed care expansion, MLTC. We did our MRT redesign, significant changes in avoidable hospitalization with DSRIP, and more recently in the last decade, significant coverage expansion with the creation of the Essential Plan, which is the basic health program. We expanded MLTC to offer integrated products. We have made significant expansions for limited eligible members who have Medicare coverage to support and pay for their wraparound services, their premiums, helping people who are eligible get Medicare Savings Program. We've helped over 100,000 elderly get into that program in the last 2 years, expanded postpartum coverage. And last year, we got 2 very large innovative waivers approved that we're implementing now and that are somewhat in the crosshairs with respect to what was just signed into law earlier this month. So all those changes over decades have resulted in this complicated chart that essentially shows how New York has created a continuum of options on the foundation of Medicaid. So you may think, some people say New York's program is incredibly generous. The Medicaid program is more generous than others. And I'm going to show you later on that some of these percentages are actually very similar to what the national averages are. What we have done that is unique is build off of that base with the Child Health Plus program, which is at the bottom of this chart, where children, families whose income can go up to 400% FPL have the option to pay into coverage, but only 30% have to pay premiums. And those are the ones above 233% of the FPL. But we've obviously expanded a tremendous amount with the essential plan. And that starts with the, I guess, magenta in the middle with the 100% FPL. And I will talk a little bit about this later, but the essential plan is significantly impacted by the legislation that was put forward or signed into law, to the tune of half of the program funding is going to be eliminated. And I don't know any program that can remain as it is with half of the funding to operate. So significant changes in EP. But as you'll see with EP 3, 4, which are or 4 and 3, that is similar to the Medicaid population. These are primarily lawfully present immigrants outside of the 5-year bar that we call the Aliasa population. And when EP was created, those individuals were eligible for tax credits and are currently covered. There's about 700,000 between 3 and 4 that are currently covered and whose coverage may change as a result of the bill. And then the 1332 waiver is the 200 to 250. And then above that, people are eligible for tax credits on the exchange. And so you have this sort of sliding scale and continuum that as families, as income changes, the safety net is structured as such that they will still have and retain comprehensive coverage that's similar across these programs. And that is one of the things that makes us unique, because we have built a continuum of options. We have a very low uninsured rate. About a third of the population is covered by Medicaid. Half of the population is covered by one of these public health insurance programs. That's what took our uninsured rate from the 10% it was prior to the ACA to the below 5% that it is at the moment. And what is not shown on here that should be mentioned is we have one of the lowest uninsured rate for children, thanks to what we do in the Child Health Plus program, and you'll see that in subsequent slides. But this is something to be proud of in terms of what we've been able to accomplish in a decade. What else makes us different? We have a pretty robust state plan benefit. And what is a state plan benefit? It's the benefits that are available to all enrolled and eligible Medicaid members, whether it's fee-for-service and or managed care. We have tremendous preventative services that are built into the state plan, kids' mental health services, school-based services, a lot of the social need services between transportation and nutrition, and more recently with the doula expansion. But a lot of these things, Governor Hochul has championed. We've made tremendous investments in and formalized in the last 5 years. And we do think that these changes will pay off later on. They're already paying off now, but in terms of the impacts in the federal context, they'll pay off. And more importantly, there's very little cost sharing across all of these programs. There's very little barriers to getting into the programs. We have a robust facilitated enrollment program. We have very high touch points and very low bars as it stands today. And what we'll talk about in the federal context is there's a lot more red tape. There's a lot more administrative requirements. There's a lot more rules, paperwork, and processes that are effectively rewinding the clock to go closer to how it was in the pre-ACA days. We've made, as I mentioned earlier, we have the #2 highest number of dual eligibles in the country in New York, very high proportion of elderly. We've done a fantastic job, including a couple of years ago with our expansion of the Medicare Savings Program to help low-income seniors keep supplemental Medicare benefits, not have to pay premiums or cost sharing. And it's helped hundreds of thousands of people keep their and get access to Medicare. It's helped enroll them into low-income subsidy programs so that their Part D drug costs go down. So we don't get enough credit for what we've done here to wrap around other programs and really strengthen them, but we really are leaders in that space. And then, we have a lot of managed care programs, and I know there's a lot of feelings about those managed care programs. But some of them work really, really well, including the biggest one we have that covers 4.5 million people, this mainstream program. A lot of the people in that program are the ones subject to a lot of the changes that we'll talk through. But it has consistently ranked higher in terms of quality access and performance to peer states for that program. And I think it's something to be proud of because that's what covers the most people. And ultimately, those people have access to all the comprehensive benefits. So Medicaid in New York, I just took this from Kaiser, and I just wanted to show it has a lot of good information about what do we cover, who do we care for, where, and how do we compare to other states. And I'm realizing Kaiser made a mistake, so I'll call that out in a second. But like other states, we have about a third of the people in Medicaid. Many are children, 40% on average are children. In rural areas, as many as half of children are covered by Medicaid. That's significant because the rural communities are heavily impacted by this legislation. And I know, the talking point from the federal government has been about traditional enrollees, preserving them. And as you'll see, these things are interconnected, and it's hard to cut the program by 15 to 20% and say that it won't impact all populations. But many of our populations have chronic conditions. We cover half the births. We are the primary payer for behavioral health services, long-term care services, critical lifeline, over $100 billion, a third of our economy. Very big deal in terms of its impact. Most people already work. Over 70% of people are working. Those that are not working are caring for our caretakers. Their parents are going to school. They're doing childcare. And they're going to be heavily impacted with the new community engagement requirements that we'll talk about. But this slide at the bottom is a comparison of New York to the US median in terms of our eligibility levels. And you'll see the areas where we are generous or more generous than the average is for children. And that really relates to the Child Health Plus program, where we go up to 400% FPL. That's on the left. Pregnant women were a little bit higher than the average. But by and large, everywhere else, we are, where we should be. It's not that we're overly generous in who can be eligible for the program. We just offer a comprehensive benefit package that focuses on preventative services and has a lot of opportunities to improve health. The one area that Kaiser made a mistake is in this second to last column, this people ages 65 and people with disabilities. Thanks to Governor Hochul's leadership in 2022, we aligned the income eligibility for all adults. So this is not 81%, it's 138%. And we did that prior to the unwind to facilitate the unwind, but also why would the most vulnerable have more restrictive eligibility criteria? Somewhat counterintuitive. So all in all, that is the area where we are different. It's children and the elderly and disabled. So a lot of busy, dense charts coming up, so bear with me. So what this is a snap, 10-year view of our Medicaid enrollment, which is broken down by category, which is at the bottom. Chad, you didn't update my slides. So starting at the top, it's in all other category. You can kind of ignore that category. It's a range of different people. But then below that, in the blue, is ACA expansion adults. Below that in the green are people over 65. Then it is the disabled population in orange, and the navy blue is children. When you look at this chart, it's hard to really see what populations are changing over this 10-year view, this macro view. As you drill down, you would see that the areas of growth are the ACA expansion adults and the elderly. Everything else is pretty consistent over this 10-year period. The ACA expansion adults are a heavy, heavy focus of HR 1. And so that blue is probably going to go down due to some of these changes. The bill doesn't do anything to address the increasing cost of caring for the elderly, which is the largest driver in the program and has been for the last decade. If you look at this chart, you'll see a growth trend at the top. We added in a per member per year for all enrollees, limited benefit, full benefit. And I wanted to show that because I think a lot of the same cost pressures we're facing right now and the challenges that lie ahead, with the exception of the changes in immigration status and eligibility, I don't know what it is, they're not changing in this bill. We still are going to have these underlying cost pressures. In 2015 to 2020, we began to see the proliferation of excessive home care utilization and spending growth in the CD Pass and personal care program. We then proposed some reforms, but then the federal PHE hit. Everything was halted. Everything was frozen. Utilization plummeted, as you'll see in the 2020. And then we've slowly been rebounding. And if you were to assume that this federal PHE period didn't exist, it's kind of like that trajectory would hit right where it is in terms of the increasing per member per year expense, which is significant. This is a huge point of criticism. People always say, you know, New York's program is one of the highest in terms of how much you spend per member per year. And what's funny is those are the same people supporting the cuts, and what the cuts are only going to result in these numbers going up in terms of the cost per member per year. And I'll explain to why that is, but it's primarily that the ACA adults and the people that are subject to a lot of these changes, they're very healthy, or they're generally healthier than the traditional Medicaid population. They're not very expensive. And so they help spread a lot of risk. And that's really what insurance is about, is spreading risk. And so as we take out the healthy, less expensive people from the program, the cost of the program goes up. And that's something that hasn't been said very much, but it is true. Our premiums are going to go up. It's a fact. So that is going to add to those existing cost pressures that this bill does nothing to address, which is why New York is so disproportionately impacted by this law. And that doesn't even include the essential plan, which I'll talk about later. But if you look at this chart, I would start at the bottom. The first four gradients are Medicaid groups. So all we're doing is the prior slide, we're just adding on from those four Medicaid groups, then we have Child Health Plus and an EP. That's what's on the left. And it's a comparison of what it was in 2015 to what it is, more recently. Significant growth, a lot of it driven by EP, which is a fantastic and generous benefit. But a significant growth in the ACA adults too, or just generally adults. On the right side is the per member per year, and this is in thousands. So in 2015, adults in the Medicaid program cost on average about $5,500 per year. Today, they only cost $5,800 per year. And that includes all the investments we've made in the program and the benefit. So very, very inexpensive relative to the other groups I'll go through. Another relatively inexpensive and cost-effective group is children. That has increased in terms of the per member per year expense, still the lowest by and large, and CHIP is the lowest, but and for terms of Medicaid, children are by far and away the most cost effective. We've made a lot of investments, but even still, they are not costing an excess amount of money per member per year. Then we get to the age population. And in 2015, we were probably higher than the average, but it was $30,000 per member per year. It's now $42,000 per member per year. That's a 50%, almost a 50% increase. Similar story for the disabled, 32,000 in 2015. The disabled population will be the highest on all Medicaid programs, but we are still higher on average. In terms of the cost, now it's $44,000 per year. So if you start to think about the math here, you are losing a very high number of enrollees potentially who don't cost an eighth of what your traditional enrollees cost. And your mix of enrollees now looks a lot different. Your risk profile looks a lot different. The insurance market looks a lot different. And so there are these offsetting costs that we can't yet quantify, but when people talk about, you're going to save money because people are going to come off the rolls, the answer is yeah, but it's not enough, A, to make up for the loss, and then B, it actually may increase our costs in the long term, or certainly because we have to, in a state that is 75% managed care, you can't really avoid those premiums changing due to the change in mix in your population. And then we have the EP, which is a little bit more expensive than our traditional adults and Medicaid due to the reimbursement rates and other things that have been benchmarked to the commercial market in the qualified health plans. So that's a little bit of table setting. Now to even more dense slides that I'm not going to read, but I will describe because as Oxiris and Melinda said, I mean, this is not even an abbreviated version of how much is changing. We met with the team. We've been meeting every day. And, our current work plan is well over 50 pages. All of those pages are new work that we have to do on top of the existing work, the innovation and eligibility and enrollment, the other advanced initiatives. But I'm going to summarize the key provisions starting with where we are today, the 2025. The bill was signed and there was some immediate changes put into place. A lot of them were financing restrictions, starting with provider taxes, Medicaid provider taxes. They were frozen. There were no new ones. This has been a big topic of debate, and every state, I think, by and large, is leveraging provider taxes much more than New York is, to be honest. We do not have a provider tax that is over 5%. The current cap is 6%, and that's going to go down, but we are not at the cap for any of our taxes, whereas every red state is at the cap for the provider taxes. So this is not as impactful in the short term for us as maybe it will be for others, but one of our recent taxes that were approved, the MCO tax, which is intended to pay for and invest in provider reimbursement rates, may not be here to stay. We don't know. There's a proposed rule, but there's a lot of attacks on the provider taxes, and that is usually a mechanism that New York State uses to reimburse providers and enhance the reimbursement rates for providers. Similarly, with state-directed payments, we pay hospitals through state-directed payments. We have value-based payments through state-directed payments. That is sort of the mechanism to make innovative payments in managed care and ensure that they get to a particular provider at a specified amount per service. Those that had previously been able to go to the average commercial reimbursement rate. That's what the current reg or prior reg said. They're changing that to cap at Medicare, which is the traditional requirement in fee-for-service. Unlike other states, we don't abuse this too badly. But we do have approved state-directed payments that pay above Medicare. And that is for the safety net hospitals, many of which are participating in our waiver. And for hospitals in rural communities like critical access and Soul Community hospitals, who are heavily dependent on Medicaid, just given the population mix and requirements of being one of those federally designated hospitals. They are grandfathering approved state-directed payments. So, there's a little bit of relief there, but the legislation requires in 28 that anything that is currently above Medicare, we got to start phasing down by 10% a year until we hit that Medicare cap. And unlike the other states, we're going to hit that cap quickly because we're not that much above Medicare in our payments. But this is going to have significant impacts on hospitals because this is our primary payment mechanism to pay enhanced reimbursement rates to hospitals. So if that is going away or being capped at a level that is below what we're doing today, there's going to be implications to that. And we're going to have to prepare for that. This does not even account for what I will describe later on the work requirements. But other things they did was whatever the Biden administration did, let's reverse it. So they limited and put a moratorium on all these great rules about streamlining eligibility, all the things we learned from the public health emergency that were done terribly and unnecessarily and negatively in terms of helping people keep coverage. They're halting from streamlining those changes. They also are halting the nursing home safe staffing implementation. I think the moratorium is until 2034. So those great things are not happening. And then we have immediate implications for the essential plan starting in 2026 in January, literally less than 6 months away. There are a range of different provisions, and you may have seen presentations from the governor's office about this and the significance of this impact. Governor Hochul has been really out there since the early iterations of the House bill, sort of clamoring about this. It was not addressed, and it puts the essential plan in the crosshairs, as you may have seen from the New York State of Health presentations and resources on their website. But what it's doing is on January 1st, 400,000 people, 400,000 lawfully present immigrants with incomes below 100% FPL, less than $20,000 per year, are no longer going to be eligible for premium tax credits. So those are the tax credits they get to get subsidized marketplace coverage. And due to their income being so low, those tax credits are really high. Those that is not half of the EP program, but that 400,000 people, it's a significant portion. These are billions of dollars that are being taken away and out of New York's delivery system. Fortunately for this population, they will retain comprehensive coverage due to the state constitution, but it's really more about the funding and the federal government's relinquishing its funding obligations for this group that is going to have implications for the broader EP. And we don't know exactly what we're going to do yet. We're working really hard to think through, but this is literally 6 months away. And designing around this, planning around this is very challenging and uncertain, but that is, very significant. Later on in the year, they also have changed the definition of eligible alien, non-qualified citizen. There are populations that have been eligible for Medicaid since the program was created that will no longer be eligible for Medicaid, or will no longer be eligible for federal money. Those include populations like refugees, asylees, victims of domestic violence, many lawfully present immigrants. It's very archaic and draconian, as Oxiris shared. It's hard to really understand these changes, just given, this is probably less than 100,000 Medicaid enrollees, cover 7 million. So it's not a huge amount, but it's the sea change and the commentary earlier that we are in a different world. It's things like this that really hit that home. And as saving grace, they offered a rural hospital transformation fund that is available to many non-rural hospitals. In the following year, more EP changes that impact the group above 100% FPL. So slightly higher income. Similar impact, no longer get tax credits, but then they're doubling down and saying, yeah, some people aren't even eligible for marketplace coverage. Some of the lawfully present immigrants will not be eligible for marketplace coverage. So all in all, these two purple 26, 27 for EP, that's 700,000 people. Really, really significant. And so we're working really hard to see what our options are and do everything we can to preserve coverage. 2027 is a crazy year, super important year with our waiver renewal. And it is like where everything is changing in this piece of legislation because, it's currently drafted that by January of 27, we have to implement community engagement and work requirements, which I'm not going to get too into, but it is hard to imagine how we will be able to do this in the next 18 months, knowing that we have 3 eligibility systems, a legacy system. Some of these individuals are covered in our local districts. There's no guidance as to how it will be implemented. We may not get the guidance until 6 months before we have to implement. So designing around that, planning around that is a challenge. We have to assume we have to do the impossible. And, you know, to Melinda's earlier point, when you're making design decisions quickly, there are trade-offs, and some of those trade-offs are the member experience, which is something that we and our eligibility team, who is the best, like, we are so lucky to have our eligibility team between NISO and the Office of Health Insurance Programs. They will mitigate a lot of these impacts and make it easier for people, but in some cases it's really hard, and we don't know what flexibilities we'll have with the federal government. But, you know, they don't really love New York at the moment, so I don't anticipate there will be any saving grace here, unfortunately. To make matters worse for this ACA population, there's stacking changes. So they're subject to work requirements. They're going to get their eligibility redetermined every 6 months. And they no longer can be retroactively covered in Medicaid beyond 30 days. We currently have a 90-day retroactive coverage requirement. It was critical in the unwind, as we showed you at the UHF stakeholder convenings. That's changing. It is going to be on us to make sure people are aware that we are reaching them, that they know what to do, what to bring, and where to go to keep them covered. Because this change, while it's making ACA eligible populations, they only have 1 month. Traditional populations have 2 months. So there's still a reduction for all. And that includes the Child Health Plus program. So this is going to take a lot of outreach, education, awareness. But the point is, so much is changing at the same time, stacked on top of each other. It is hard to know how to mitigate the most efficiently and effectively in this short, condensed time frame. But those changes, heavy target on the ACA population. The federal government is clearly tired of paying the 90%. That much is obvious. And then the immigrants are the other area they're focused on. And that's, you know, for various reasons, but that is not really a cost issue. But those are the two groups that are going to be the most impacted by these changes. And 2027, by far and away, the most important year. There are changes to budget neutrality, which will impact our waiver renewal. I know I'm over time. The change is essentially that the chief actuary at CMS, Office of the Actuary, is now going to have to review and approve budget neutrality, which is a calculation of whether, if we didn't do your waiver, it would cost the federal government more or not. And it's unclear what that will mean with the chief actuary, but needless to say, I think we're going to expect more rigorous evaluation, maybe changes in methodologies. We may not have as much flexibility in how much we can spend under our waivers. Again, rural hospital program, it's 4 years, a little bit of money each year. One other important marketplace change I don't want to lose sight of is the pre-enrollment verification changes, which take effect in open enrollment for 2028. These are changes that effectively require us to check immigration status and/or address, residence, you know, standard things that are previously we did not have to check each and every year. Some people's immigration status doesn't change. So we weren't, you know, federal government said you don't have to check all the time. Now they're saying you have to check all the time. And so that we expect is going to have some implications on open enrollment in the later years. And then we have to impose more cost sharing on the ACA population. And again, in 28, the payment financing mechanisms of Medicaid, the state directed payments, the provider taxes, those start to phase down. So they've staggered this with intent, right? You won't feel all these changes right away, but they are still as significant as they sound. And these will have wide-reaching impacts on the program. The program is going to be downsized once these changes are implemented by at least 15%. And that's been reported by Kaiser, by Manat, by everybody. And there's some other changes as well. This is an abbreviated version. What does that mean for us? New York is impacted by far and away, I think, more than anyone except for California. You heard the 1.5 million in coverage loss. 75% of that is assumed through work requirements. But the other changes are really the eligibility related provisions and the changes to non-qualified immigration status. So there will be losses of coverage as those things change. Fortunately, in New York, we have some safety net programs that they'll get coverage, but there are people who will be uninsured and have their coverage change. This does not include the 700,000 essential plan members I mentioned. So it only includes a portion of them, 200,000. $13 billion a year. A lot of that is federal funding for the essential plan. Half of the program's funding, as I mentioned, was going away. It's about $7.5 billion. Is a $14 billion program. The other impacts relate to the MCO tax and other financing flexibilities we have that we're not anticipating continuing. There is an increased share of Medicaid. This $3 billion, you may have heard the budget director cite this as our 2027 deficit. I think this is a conservative number. When we did the projections on the House bill, the range was 3 to 5. Because a lot of this is attributable to the 500,000 Aliesa members who are in EP today, that if, when they lose tax credits, if we don't cover them in EP, they'll still get Medicaid coverage. So they're not necessarily losing insurance, but we have to pay for that state only. Very expensive. And then can't understate the provider losses and how these changes flow through to providers in the delivery system. Care that is currently being delivered will end up being uncompensated. It won't be clear when and where. Providers will find out when claims get rejected, things don't go through, and the people that are being cared for will still need the care. So we anticipate, and it's been reported very widely by the Greater New York Hospital Association, the Community Healthcare Association, uncompensated care is anticipated to increase significantly, and we do not have more money to pay for uncompensated care. So very tough choices, very hard to know when these impacts will be felt by providers, but it's hard to imagine any scenario where they don't. And looking ahead, I can tell you that we are working day and night ever since this bill was passed. We recognize the importance of the jobs that we have. We recognize that we can make a difference, and we will make a difference. Chances are we will not be able to mitigate all of the impacts of these changes, but we're going to do everything in our power to do that. We have outperformed expectations before, as recently as a public health emergency. No one thought we would retain as much coverage as we did. It was due to the dedicated effort of those eligibility and enrollment subject matter experts, and including those in the New York State of Health. And we're working on this day and night, and we'll do everything we can. We will convene and engage and update when we have more information. We're waiting for information from the federal government. Hopefully we get it, but it does dictate how we plan and what may happen and when. And then we're going to leverage our infrastructure, work with state agencies. The state does have a lot of data. We are hoping we will be able to leverage automation to automate some of these new enrollment changes. Again, unclear, but we're going to leverage our infrastructure and build on the process improvements from the PHE, which if you go to the New York State of Health website, you'll see what that progress is. Just to close, because I do want to get to Q&A, and there is no sugarcoating it. This is going to be really hard. It's certainly not what I envisioned as having to deal with when I became Medicaid director, and I don't think any other Medicaid director would say that. But I can tell you that it is a renewed sense of importance and recognition of how impactful the work we do is on people. And I think every person in the Department of Health, especially in the Office of Health Insurance Programs, New York State of Health, knows that and is going to be here to help these people and some of the most vulnerable in our state. And we will get through this. I am confident in saying that we will get through this, but things will look different. We have to be creative, innovative. And sometimes desperation is the biggest motivation and driver of innovation. And that's how we're looking at this. So thank you. I look forward to your questions and
Thank you for your presentation, Amir. Hi, everyone. I'm Alessandra Tavernatrani. I'm the Managing Director for Medicaid at UHF. We're going to be opening the floor now for a brief Q&A. You could start to line up the mics. In the meantime, we'll take a question from the folks online. First question. How's the state thinking about the future of emergency Medicaid under broader coverage reforms? In particular, are there any anticipated changes to eligibility, scope, or the way emergency Medicaid interacts with coverage and care for undocumented populations?
no, there will not be any changes for emergency Medicaid. It's one of the things that they didn't touch and mess with in this bill. And I think the implications would be, we anticipate there will be more emergency Medicaid as populations become uninsured. Hard to predict when that will happen, but no anticipated changes on eligibility, reimbursement, coverage. And so that will remain as it is today and be the lifeline it is for those in an emergency circumstance.
Thanks. How do you see HR 1 impacting New York's Medicaid value-based care efforts, particularly in light of provisions that limit provider taxes and cap state-directed payments?
You know, there's a number of ways to look at it. In some ways, I think it necessitates more value-based payment, and that we have to think creatively and differently with some of our incentive funding, or we have quality incentive programs. There are things we can do that are flexible and that relate to quality improvement. They're limited, but we can do more in VBP there. I think the counter to that is the insurance industry is facing tremendous pressure in terms of medical inflation, acuity changes as populations, shift off different roles. And as those pressures build, coupled with the funding reduction, you have to be mindful of where those dollars are going and ensuring that you're getting max value. So I do think value-based payment will stay, and those that do it well will double down. But those that are dabbling and maybe in an intermediate stage, maybe less willing due to the risk involved. But I think the combined pressure of the plan, insurance pressure, and just the funding going away, I think we expect to see less, but hoping that some of our leaders in the space, some do only value-based payment, will lead the way and show why value-based payment matters.
Thanks.
Hi, Amir. Mark Levy with Blue Cross Blue Shield Anthem. Masterful discussion of incredibly complex changes that are coming our way. So thank you for that. And also the call to action. And just to double down on that, 1,000 people here are really the leaders in New York. Definitely. That are accountable to make sure that the impacts of these changes are minimized on the people we serve. One question I have for you is adverse as our federal government is to rulemaking, the current federal government, there will need to be rules that come out to sort of give us the roadmap in terms of what they expect from us. Do you have any insight into sort of the timing or what you see for rulemaking from the feds in terms of how we're going to do all this? Yeah. Thank you.
Thank you, Mark, and appreciate the comment and your leadership in your role. Yeah, rulemaking, there are some specified timeframes in the legislation for when the Secretary of HHS has to put out certain information. The unfortunate part is, they're not following all of the rules that are in place. And even those timelines, it's almost like, you find out how to change an entire system 6 months before you have to implement it. It's not very helpful, at least in the context of Medicaid, with moving, archaic systems, modern systems in parallel. But we will get more, they've made some rules already, as you know, with the provider taxes, state-directed payments. They will put out regulations on work requirements. The legislation does include a lot of those exemptions and how some of the framework, but they will put out those regulations, and then they need to tell states what is designated a good cause exemption. If you need 2 years, like what are the criteria? And what will you have to do? Again, unfortunately, sobering fact, the federal government does not care about us as much as they used to. So it's unclear, but I think based on recent actions, we're not banking on getting those federal guidance documents and materials prior to things having to change. I mean, the EP changes, I think, and I saw Sonia Sekar in the room. We're supposed to be getting notice today because after 30 days of a federal waiver change, they have to tell you, yeah, federal law change, this is how it changes your waiver. So we haven't gotten that yet. We haven't gotten anything yet other than what everyone has seen, and I wouldn't hold your breath.
Good morning, Amir. Adam Aponte, I'm the CEO for the East Harlem Council for Human Services. I run a federally qualified health center. And so, as you know very well, FQACs are really in concern with these changes. You showed a stat earlier, $300 million for FQACs across the state. And as you also know, FQACs are already facing rate challenges in that our rates are based upon 1999. We've been trying to get those rates lifted for quite some time with no success. And with now this decrease in funding to the state in terms of Medicaid, we feel like this is going to be a double whammy for us in particular. So many FQACs are really concerned about this, right? So we're going to lose patients because of the eligibility criteria. Our funding has never been quite adequate in terms of rates, and now we're losing further funding that we don't think the state's going to ever now address that rate reform. Any thoughts on how we survive as FQACs?
Yeah, great question. And I think the rate reform, we more than happy to talk about that. It's a lot more complicated. We work around the rate issue to help FQHCs, as you know, with our investments in the 340B and other alternative payment methodologies. Maybe I am optimistic, but talk about an opportunity. I think FQHCs have opportunities that I'm encouraged by that may not be available to other providers. So, alternative payment methodologies, that authority still exists. That allows us to pay FQHCs separate from the traditional PPS rate. It's on top of the PPS rate. You can have flexibility in methodologies. So that's not going away. If it does, the federal government would have to say to every state, no more APMs. Very unlikely that would ever happen. So, that's encouraging. There's a pathway, right? We do have an uncompensated care pool in our state plan. That is a pathway to pay an FQHC. Some providers, there's literally no pathway. So, I am encouraged by the potential things that can be done in FQHCs. We don't know what we will do. We would like to get feedback from the industries, but we know everyone's digesting both the legislation, some of the recent administrative guidance. There's a lot to understand before you make business decisions. But I think there are opportunities to explore further.
Good morning, Denise Sofel. I'm a longtime Medicaid advocate, consumer advocate here in New York State. It's lovely to see you, Amir. My question is about health equity. I know that the state health department not that long ago changed its mission statement to explicitly embrace the concept of health equity as key to its mission. And our waiver is in fact called health equity waiver. Given that health equity is a dirty word in Washington these days, I'm wondering how you are thinking about approaching the waiver renewal and whether you're thinking about reframing New York's mission goals, values in light of the likely hostility from our federal partners.
Yeah, thanks, Denise. Good question. But I would say is the department's mission incorporating health equity is not going to change. Our goal in the waiver related to health disparities and health equity is not going to change unless they ask us to change it. We're not going to call it deny her waiver in the next iteration. We probably aren't going to have health equity in the name. We're probably going to avoid using that terminology in written documentation and in guidance. But in terms of the functions we provide, the programs we run, the goals we have, I don't think those are changing.
Good luck.
We need it. We good?
Hi, Susan Jaffe with KFF Health News. Thanks for,
Susan, fix the chart.
I'll send them your regards. Okay. The OBBB reduces state-directed payments to Medicare levels. Why is that a bad idea? And what hospital, how will that affect hospitals and beneficiaries?
So why is it a bad idea? I don't know that it's a bad idea. I mean, the principles of the Medicaid program and the federal law are the payer of last resort. There are federal payment limits and fee for service as to what Medicare will pay. I think the reality is that, that's not where we are. And so, is this the time to be hurting safety net hospitals that may be paid above Medicare? We're not paying average commercial reimbursement rates like some other states are. But we do believe that Medicaid dependent providers may need more than the Medicaid rate. They may need more than the Medicare rate. And so it's a little bit abrupt and it's unclear what the goal is, because a lot of the hospitals that benefit from these programs are the safety net hospitals. So it's not like New York Presbyterian is not in a state directed payment, right? NYU is not in a state directed payment. But so these are our rural hospitals and critical access hospitals, so community hospitals. We want to pay them more. They have less beds. There's less opportunity to generate. Their revenue base is smaller. So every dollar matters that much more in order to keep doors open, innovate and change and provide the services needed in the community. So it's the mechanism and the method by which they're accomplishing the policy change that is the problem.
How will patients be affected?
But we're going to have to talk to those hospitals to understand that. I think we do have a number of pending state-directed payments, including for our public hospital systems, because they're serving the highest volume of undocumented, uninsured, and uncompensated care. I think they're banking on those dollars coming through, and so if they don't, I have to imagine there would be changes to service delivery. And unfortunately, when that happens, hospitals go to things like very costly service delivery, like OB, maternity, and that has downstream implications and ripple effects that are not good.
Okay, thank you.
Sure.
One more.
Sure.
Okay.
Hi, Amir. Good to
Hey.
see you. Kira Klein-Peter from Deloitte. And actually that teed up our question really, really well. So what changes do you anticipate or would you like to see come to the care delivery systems in the next 5 years as some of these cuts unfold, continue to see the shift to outpatient care, hospital at home, home health, right? How do you want to see the care delivery network evolve to continue taking good care of New Yorkers, but in a more financially sustainable and reduced way?
HRSN services.